Hello and good evening. Welcome to Biotechnica and Sibia India's special webinar on navigating the future of autoimmune disease diagnosis. I hope you all are doing well. I'm your host Nitin Kapoor, product manager for autoimmunity from Sibia India. So first of all, I just want to check from all of you how excited you all are for the webinars and which part of the country you have joined in and which institution. So please use the chat box to say hi, hello, so that I know from which part of the country you have joined in. Okay, wonderful. I can see a lot of chats coming up. People are joining from Bangalore, Gurgaon. Okay, great. If you all can use the chat box to say hi, hello, so that I know you can hear me very well. Okay, fine. I can see people are able to hear me. Okay, great. So as we have gathered here today, it is an important to acknowledge that the March is the Autoimmunity Awareness Month. This time is dedicated to raise an awareness about autoimmune disease diagnosis. The present day also carries an immense significance because today is the International Women's Day. So we wish all the women who has joined for this webinar a happy International Women's Day. Autoimmune diseases impact millions of the life and it impact almost 78% of the women's. So this day actually marks an even more important to understand the complexities around the various autoimmune diseases and how important we need to diagnose and how the early diagnosis play an important role for diagnosis and prevention of the autoimmune diseases. And we have wonderful speakers joined us for today's webinar. We have Professor and Dr. C.N. Srinivas, Group Director, Laboratory Medicine from Kaveri Hospital, Chennai, joined us with us. We have Dr. Naval, Senior Consultant Rheumatology from Fortis Hospital, Gurgaon. And we have Dr. Siddharth Sharma, Clinical Head and Scientific Affairs Manager from Sibia, India. So let's hear from the experts, and over to you, Dr. Naval.
Good evening, everyone. I am Dr. Naval Mandirata. I'm a senior consultant in the Department of Rheumatology and Immunology at Fortis Memorial Research Institute, Gurugram. And I would like to thank Sibia and Biotechnica for giving a chance to talk on this Autoimmunity Awareness Month in the month of March. So, what is autoimmunity? We have been seeing a lot of cases. We have been hearing a lot about it. After COVID, definitely we saw a lot of spike in autoimmune diseases because a lot of people were affected by the virus. And why is it important to diagnose, and how does the labs help us to diagnose? So, this is important awareness message just from the clinician point of view, which I would like to point out. So, autoimmune disease is basically what we explain, like when your immune system starts attacking your own self. So you do have a system. It's a very complex system of all the cells which are meant there, and they're meant to basically protect you from the viruses, from any harmful invaders inside the body. So what we like to explain it to our patients is like somewhere you have kept a dog for the protection of yourself and your family members, but somewhere the dog goes berserk and starts attacking you, and that's how it happens in our autoimmune system as well. When it gets triggered, the trigger can be different from any person. It can be a virus, it can be a stress, which we keep talking about these days, which is a proven thing. It could have been a vaccine, it could be a simple like a dengue infection or any flu infection that sets off the whole immune system, which starts attacking your own self. Now, it is a very complex system. It's too easy to speak about it, that yes, it starts attacking, but why does it behave differently in every patient is still a mystery. A lot of people have been trying to evaluate, a lot of researchers have been going on. We have been trying to find out the test, but every autoimmune disease, or we can say this autoimmune disease of the same depth, will behave differently in every patient. One may have a very mild disease of the same variant, one may have a very aggressive disease of the same variant. And that comes to my main discussion and awareness on why autoimmune disease should be diagnosed early. So now when the autoimmune disease which we talk about, the main threatening part is the damage to the organs, which we like to call as an end organ damage. So that end organ damage, again, as I said, varies in every person. Some may have the involvement of the lungs, some may have the kidney involvement, where they go into the nephritic syndrome with the blood pressure, loss of proteins. Some may even have a brain involvement, where you can find some involvement like tissues which are growing in the brain. Some may have a seizures, or some may have a joint involvement. So autoimmune diseases are almost 200 in variant, and it's important to diagnose them early because patients may present with very vague symptoms like cough, fatigue, body ache, a low grade fever which is not subsiding after multiple antibiotics, 3 weeks of antibiotics, and a low grade fever is continuously to persist. So in a setting where you have a multidisciplinary approach, a lot of times we are able to diagnose these patients early because we have seen once you do not diagnose these patients early, the disease starts to become aggressive. And that is so the case because the abnormal cell proliferation has already started in your body. If you're not able to control the disease at that stage, it will keep on attacking multiple organs, and which we call it as a multiple organ failure. Some of our diseases, like we call it as a rheumatoid arthritis, lupus, ANCA-associated vasculitis, and especially lupus and vasculitis are such threatening that within a week they can just eat up any individual. Now, where does the autoimmune happen? So now most of the age groups which we see are young individuals. That is the ones even in the kids as young as 8 to 10 years old. And most common age group is 20 to 40, especially in the female age group. Now, think about that age group getting affected, and that is the peak age where you will be working, you will be starting to earn for your family, you will be establishing your own self. And if you get hit by these autoimmune diseases undiagnosed, and it ends up damaging your organs, so the whole life quality gets affected. Simple joint, like a knee joint, which can get damaged by these autoimmune disease, can leave you crippled for the quite a lot of part of your life, and you cannot opt for surgery for every plant. So that's why autoimmune diseases needs to be diagnosed early and needs to be treated early, so that earlier the arrest is there. For the all the studies have pointed out to the same, and within first 6 months, if you are able to arrest the disease, those are the patients which will do very good throughout the life. Definitely, it's still not a curable disease, but at least with minimum medicines, cutting down on the lot of steroids, patients are still able to lead a normal life, just like a diabetic patient or a thyroid patient, which again are autoimmune problems, but not so threatening as we see in our rheumatological pattern. And definitely, that's where the lab definitely plays a very big role in helping us diagnose inflammatory markers, the newer antibodies which are coming through, the older ones like rheumatoid factor, anti-CCP, ANA, ANCA. All these antibodies are supportive in our diagnosis. Definitely, if you ask a rheumatologist, the still diagnosis remains clinical. That 70% of the diagnosis should come before the patient leaves to your chamber from a history and the physical examination. Labs support you next 20 to 30% to conclude the diagnosis. So, hence, my take home message will be make sure that you diagnose this disease early, consult your rheumatologist, or if you have a rheumatologist in your setting, now with teleconsults also available, at least a patient can take an approach, get the consults done, and sort it out early. So, that will at least give them a good quality of life without affecting any organs. Thank you.
Okay. Greetings to everyone from Chennai. And I would like to express my heartfelt thanks to the Sibia team for including us for sharing the knowledge on autoimmune disease during the World Autoimmune Disease Awareness Month. So we'll be just going to see what are these autoimmune diseases and what are the complexities of this and what are the most common diseases we get in this and how the laboratory can help us in picking up these cases. So to begin with, there's a small case to understand how in preventive health checkups we do get simple clues to autoimmune diseases itself. This is a 32-year-old female, a non-pregnant lady who had undergone a preventive health checkup. In the CBC, we found out that she was anemic, a hemoglobin of about 8 grams, and her urine analysis showed protein to be of 3 plus, which is more than 30 milligram per DL. Based upon the clinical input, they had asked for the anti-nuclear antibodies, which is called as ANA, which is thought to be the positivity. They are also requested for the dsDNA, which was positive, which impresses to know that these two are done on two platforms, which we'll be discussing later. One on ELISA mode and another one on the immunofluorescence mode. And the diagnosis of the systemic lupus erythematosus was done for this patient. This is one of the simple cases which we are dealing it here today, but most of the time in our clinical practice, the preventive health checkups do pick up other autoimmune diseases too. Now, let us ask these questions for ourselves. What is autoimmunity? What are the causes for the autoimmunity? And what are the complications of the autoimmunity? How simple it is to diagnose in any of the routine laboratories. Now, autoimmunity refers to a broad category of diseases in which a person's immune system mistakenly attacks their own cells. Imagine your own WBCs are going to attack liver cells. Your own WBCs are going to attack the kidney cells. Your own immune cells are going to attack the brain cells. So these are the prodigy on which they work upon. Normally, what happens in a normal immune system? Normally, the immune system is protected because it is having cells to protect the invading microorganisms, such as bacteria or viruses. And we know that the body immune system is made up of a lot of macrophages as well as neutrophils, eosinophils, basophils, lymphocytes, and monocytes. In addition to this, we also have antibodies which are produced by a group set of lymphocytes which are directed towards a specific proteins to recognize and destroy the bacteria or the viruses. Now, the autoimmune diseases do occur, and when they do occur, they do have autoantibodies in their serum samples. Autoimmune or autoimmunity, if you dissect out the word, auto refers to self and immunity means defense. When there is a breakage of the self-defense mechanism, these are known as autoimmune diseases. The autoimmune diseases is the loss of the self-tolerance by our lymphocytes, which are the group of WBCs itself. The autoimmune diseases are simply classified into two groups for understanding. One is the organ specific autoimmune diseases, for example, diabetes and thyroid illness, and the non specific autoimmune diseases where it affects multiple systems like lupus erythematosus, mixed connective tissue diseases, and also sometimes the rheumatoid arthritis itself. What triggers the autoimmunity? Do we have any trigger which stimulates this autoimmunity? What is the complexity of this disease itself? Now, to understand this, we don't have a strong evidence to point out that this virus produces the autoimmunity. This bacteria produces the autoimmunity. It is multifactorial. We have not yet understood completely what triggers the autoimmunity. Does it have with hold with only one risk factor or multiple risk factors itself? They have postulations that a certain group of bacteria, viruses, toxins, hormones, significant stress, environmental pollutants, some drugs which may belong to that of Siddha group or homeopathic medicines or medicines of allopathic medicines itself may trigger an autoimmune response to a person. Now, when you list out the autoimmune diseases in the literature, we have got many. To highlight few of them, I have just got these common 12 autoimmune diseases, which we would have listened to it or you read to it. The most important being the type 1 diabetes, where you have got autoantibodies directed towards the islet cells, which are secreting the insulin. You have hemolytic anemias, pernicious anemias, especially common in younger generation, autoimmune vasculitis, celiac diseases, which is a disturbance you see in the gastrointestinal system. And you know very well about the GBS or the Guillain-Barré syndrome, which is happening in sprouts in any of these metropolitan cities and also in tier 2 cities because of a bacterial infection. Psoriasis, myasthenia gravis, Hashimoto's disease, which is nothing but autoimmune thyroid disease, rheumatoid arthritis, inflammatory bowel disease are some of the examples of autoimmune diseases itself. As I told you, what is the complexity and who are at risk of development of the autoimmune diseases and Why do they happen? These are only postulations. So age often between 15 to 24, 15 to 44 years are the people who are triggered to have the autoimmune risk factors. Women are usually affected probably because of the XX chromosomes what they do have. Environmental pollutants like chemicals, heavy metals, infections, stress are one of the causes. When we are talking about the chemicals, we should understand that the chemicals are not there in our day to our food is not free from the chemicals that we know. But the most important chemicals which are triggering the autoimmune diseases are the cosmetics. The most important being the ammonia rich hair dyes or something to do with that of the facial packs what we are having, and some of the microplastics which are there in some of the cosmetics which trigger the autoimmune disease itself. Next, we have what vaccines and antiseptics. There is a hypothesis that some of the vaccines do trigger the autoimmune diseases itself, and genetics we do not know, and the diet, especially the Western diet. Now, the diet which is rich in high protein, especially when we are getting on to that of lot of people who are going to keto diet, we have found out that the gut microbiomes changes. When the gut microbiome changes, they trigger autoimmune responses either directed towards the colonic cells or it may be multisystematic itself. Now, the question comes to all of us is, did COVID trigger the autoimmunity itself? And do we see a lot of autoimmune diseases post-COVID? The answer is yes. And some people also have a debate on this. But this is a colorful diagram. Don't worry about the diagram. But I've got some arrows which shows that the COVID do has triggered the autoimmune responses in many of them, especially with respect to that of the vasculitis. This very important group is the vasculitis, the rheumatoid arthritis, connective tissue diseases, lupus erythematosus, Sjogren's syndrome, or a dry eye and the dry mouth syndrome, autoinflammation, which are triggering many other diseases, especially with that of the seronegative arthritis, Kawasaki syndrome, and you also have got arthritis on the other side also. Now, the organ specific complications do happen. So, I already told you that you have got two groups, the organ specific and the non organ specific autoimmune diseases. The organ specific autoimmune diseases affects this organ. It may be a brain directed autoantibodies, you might have neurological manifestations, you might be having autoantibodies directed to that of the soluble liver antigen, or it could be the liver kidney microsome, and that might trigger something to do with that of the autoimmune liver disease itself. Non-organ non-organ specific autoimmune diseases usually affects two major organs. One is the kidney, the other one is the liver. In addition, skin also gets involved. Of late, where we are having the reproductive health consciousness among the general public, the reproductive health is having the brunt of the autoimmune diseases, and especially when people are struggling to have the siblings or the children, they come and visit the IVF clinics where they pick up a lot of autoimmune antibodies against the sperms as well as that of the antiphospholipid antibodies which are coming under the antiphospholipid syndrome. The sexual wellness is also directed by the autoimmune factor because the germ cells may be affected by the antibodies, and that might trigger to that of the poor quality of the sperms and the ova itself. Now, this is to summarily to say the autoimmune facts, what is the prevalences in the general public. Though it is with respect to that of the Western population, more or less it sounds good with that of the Indian population also. 1 in every 5 people are affected by the autoimmune disease, and more than 100 autoimmune diseases are impacting many people every day. As I told you, women are the most predisposed genetic group, and we do not know the reason. The only reason which is postulated is that stress and the hormones related to the female genital system, like estrogens and progesterones, and especially with that of the prolactins also. Most of the time, these producers, the commonest is the lupus, next is the rheumatoid arthritis, and you get Crohn's disease, which is affecting the GI system, Graves' disease and Hashimoto's disease affecting the thyroid, psoriasis affecting the skin, You have got myositis infecting that of the smooth muscle cells as well as that of the skeletal muscles, vasculitis, sarcoidosis, autoimmune hepatitis. We do get all these, and the pickup of these diseases in the clinical scenario as well as that of the clinical lab assistants are growing day by day. Now, few things to study about three important autoimmune diseases is rheumatoid arthritis. We know that rheumatoid arthritis do get the deformity in the small joints of the wrists as well as that in the legs, most commonly in that of the fingers itself, where they get the deformity. Few people develop dry eye syndromes and dry mouth syndromes, and they do have sometimes pneumonias. Then you have got skin rashes, skin nodules, kidney may be affected by amyloidosis. You might have a huge spleen. And the most commonest presentation will be that of anemia itself. Next is coming to that of the lupus erythematosus. Again, it is a non-specific organ diseases with that of the autoimmunity itself. They usually present with that of the skin rashes or extreme fatigue, headaches. You might have hair losses, which is called as geographically alopecia, mouth ulcers, most importantly, again, anemia, proteins in the urine, and you might be having tingling numbness sensations in the fingers and swelling of the feet in the legs and the hands. The other important autoimmune diseases which we are seeing nowadays in the clinical workup is antiphospholipid syndrome. Now, how do we pick up these? Picking up is like this. Most young generations who are undergoing strokes, especially the brain strokes, heart attacks, and these are the commonest manifestations of the antiphospholipid syndrome. In addition to this, people who are having issues in fertility do have antiphospholipid syndrome, especially the females itself. People who have got recurrent abortions, again suspected to have antiphospholipid syndrome. Now, most importantly, you should understand that the antiphospholipid syndrome can be easily picked up early whenever you are attending to the preventive health checkups itself. Now, what are the consideration you have to take into the mind to undergo this antiphospholipid syndrome? Though you have this emergencies of the strokes, but do we have any preventive checkups which can help up in picking up this antiphospholipids syndrome? Yes, we can have like PT-PTT testing, that is a prothrombin time and the activated partial thromboplastin time, which might suggest this patient might be having an antiphospholipid syndrome, which might trigger further workup for the same. Now, coming to that of the facilities which are there for picking up these autoimmune disorders, any of the autoimmune laboratories do provide you multiple technology for picking up the autoantibodies and the associated surrogate markers, which might start from immunofluorescence to ELISAs or a monospot ELISAs nowadays. You have got blots, you have got agglutination tests, turbidometry, nephlidometry, and counter immunoelectrophoresis, which can help up in picking up of connective tissue diseases, rheumatic diseases, vasculitis, which we had listed in the previous slides itself. Now, the story of the autoimmune diseases can begin in any of the divisions in the laboratories. I've got here a few slides and few examples for you. Urine analysis, most importantly, please, when you are going for a preventive health checkup, ask for a complete urine analysis. And if the urine analysis is showing proteinuria or hematuria, it might be clue to one of the autoimmune diseases which is affecting the kidney. Next, in hematology, the most important test is the test which we do is the CBC, which is called as a complete blood counts. And when you have a complete blood counts, you might be having the red blood cells to have a low volume, that is called as anemia, hemoglobins are less, WBC may be low, you might be having a low platelet, which are again clue to autoimmune diseases. Coming to the chemistry and the serologies, in the chemistries, you might have abnormal liver function test, or might have abnormal renal function test or abnormal electrolytes, which might trigger workup for an autoimmune disease. Immunoassays, especially with that of the hormonal assays, with that of the thyroids, where you got hypothyroidism, may trigger investigation for autoimmune disease. Recurrent infections of the urinary tract as well as recurrent infections of the upper aero or a lower aero respiratory system may also produce the pathway for autoimmune diseases. And sometimes, because of the clinical suspicion directly, the immunological labs might help up in picking up the autoimmune disease itself. Now, the most important test for the autoimmune disease being the ANA. ANA is anti-nuclear antibodies. Testing of the anti-nuclear antibodies can be done many ways. One of the commonest ways is immunofluorescence, the second being the ELISAs. Under the ELISAs, the technology has grown so much that we have today the reports generated within 1 hour, thanks to the monosport ELISA system, which works beautifully well with the Sibia systems. Now, the ANAs are usually done for the diagnosis, to subclassify the diseases, to monitor the connective tissue diseases, or to exclude the disease suspicion itself. Now, immunofluorescence is a simple procedure, takes about 2 to 3 hours, works with that of a very good competitive technical group who will be able to perform the immunofluorescence assays. And these are the steps. And you have to view the slides which have completed the immunofluorescence assays within a span of 3 hours, or you should preserve this to see under the microscope in the next few days itself. Now, coming to the support of the Alligram for the detection of the autoimmune test disease analysis, we have been using this machine from past a year, which is a fully automated walk-away machine, which helps us to process the primary tubes, start samples, and the reports are available within few hours of putting the samples itself. There is a continuous loading option. Multiple tests can be done in one round, and most importantly, the accuracy and the precisions are so beautiful that we have verified the tests of the ANA, dsDNA with respect to that of the immunofluorescence, and we have got 100% tallying results, which that of the positive samples to that of the negative samples. And it's a beautiful system to have this as a machine in your laboratory. It can also be working with that of the high outputs or the low outputs also, best for both medium and small size laboratories. Now, coming to the immunofluorescence do have multiple substrates. People work up with Hep2 cells, people work up with primary liver, then they work up with rat stomach and rat kidney, and sometimes they work with multiple chip options which are available in the market, and it can pick up other antibodies like anti-smooth muscle antibodies, liver kidney microsomal antibodies, anti-mitochondrial antibodies, liver antibodies, as well as that of the ANA itself. Now, whenever we see the patterns of the ANA, we have to follow the ICAP pattern of reporting, and the reports do carry the number of the ICPAP pattern, what is the titer and what is the positivity intensity in this testing itself. Now, the laboratory and the clinics has to speak together. The communication has to be established between the clinics and the laboratory. And as a laboratorian, from my point of view, we should always have a case discussion based upon every positive samples which we are getting. The clinicians should also know what tests have been offered, their accuracy, positive predictive values, and the negative predictive values, and the turnaround time plays a crucial role for the length of the stay of the patients, either in the outpatient department or the inpatient department itself. So, to summarize, autoimmune diseases are common in our population. It can be easily picked up by surrogate markers like anemia, leukocytopenia, thrombocytopenia, urine where you shows protein, or it shows hematuria when you have. And some of the thyroid panels do indicate that this patient might have autoimmune disease itself. So in short, the laboratory which offers the testing may offer you immunofluorescence, they may offer ELISA system, or they may offer even the other specialty tests itself. Please do interact with the laboratory to know more about picking up of these autoimmune diseases, so that we can save the patient and we can enhance the diagnostic skills to make sure that we have a healthy population itself. Thank you very much.
So, good evening, all. I'm Dr. Siddhartha Sharma, heading the Clinical and Scientific Affairs at Sabia, India. And today evening, I'm going to speak on advancement in diagnostic technologies for autoimmune disorders, the advantages of using a monotest ELISA technology. So, as you are all very well aware, autoimmune diseases are very challenging to diagnose and to treat because they can affect any organ system and have many symptoms in common. So, clinically and laboratory wise, it is also very difficult to diagnose and test for the same. Also, importantly, they may progress rapidly or fluctuate between flare ups and phases of inactivity. So, it is very important that the diagnostic tests are sent in which activity, disease activity, whether it is a rapid flare up or is it a quiescent phase. So, it is very good to understand that there are activities of activeness and inactivity in an autoimmune disorder. So, the timing of testing also becomes very important. So, autoimmune disease diagnostics is very complex. So, as you can understand from this figure, on the y axis, you have the autoimmune disorders listed, and on the x axis, you have the various biomarkers for the same listed. And as you can see, for any particular autoimmune disorder, there are many biomarkers, and some are shaded dark blue, whereas others are shaded light blue. So the idea of showing this very busy and complex slide is to make the audience aware that there are many biomarkers which are associated with a particular autoimmune disorder. But what is important is to pick or test rather for those biomarkers which are both clinically and diagnostically significant and which form a part of a particular guideline, because with kind of overlapping of clinical symptoms that these autoimmune disorders have, it is imperative to precisely classify a particular autoimmune disorder with the relevant biomarkers. So as of now, in the diagnostic algorithm which exists for any autoimmune disorder is, we have the initial screening part in which the conventional immunofluorescence assay testing is done, where we test for the ANA or the anti-nuclear antibodies, as the terminology goes, on by using an immunofluorescence microscope, and this is primarily used for screening the population for autoimmune disorders because it offers a higher sensitivity. But then we need to, apart from screening, we need to confirm whether the functional antibodies for a particular autoimmune disorders exist or not. So for that, we use our solid phase assays, and we do you have ELISA testing which can be used for confirmation of existence of a particular autoimmune disorder. And third is differentiate. Again, because of the overlapping of the symptoms and overlapping of various markers in autoimmune disorders, to precisely pinpoint which autoimmune disorder is there, we need to again test specifically for a particular autoimmune biomarker. So the protocol is from a screening to a confirmation to differentiation. So what are the current techniques which are available for testing and screening of an autoimmune disorder? So we have the classical immunofluorescence assay, and then we have the solid phase assays, primarily the enzyme linked immunosorbent or assay or the ELISA, the CLIA or the chemiluminescence assay, and then we have some immunoblots or the dot blot techniques. So when we talk of simplifying the complexity of testing, Sabia has brought about a solution called Allegria Lab on a Strip solution, and this is a proven excellent technology which has been prevalent now for more than 15 years, where we have ready to use reagents and pre-filled Allegria monotest strip. So it's a monotest strip ELISA based technology. I will be just elaborating it a bit more in my subsequent slides. So these are barcoded strips which include all test relevant information, and primarily the proprietary USP or technology associated with these barcodes as with the strips as the SMC technology, or what we call as the sensotronic memorized calibration. Then because of this presence of this technology, each test is validated, which leads to generation of high quality, that is accurate and precise test results. So what is this SNC technology which is associated with this monotest strip? So SMC is nothing but sensotronic memorized calibration. So as you can follow my pointer on the left side is a strip which is covered with a barcoded foil, and this foil contains the SMC barcode information. So basically the calibration which is there, which is associated with any ELISA test, is barcoded in this particular foil, special foil. And this foil, this barcoded information is directly read by the instrument, and it generates a uh, calibration curve. So it becomes very easy for the operator. It negates the initial manual calibration which needs to be carried out with the conventional ELISA test, which is a pain for any operator to generate high quality results. So out here, it is all barcoded information, which is pre-fed, which is lot specific, and it is directly read by the instrument. So no need for doing extra calibration. So these are the test strips. These are the test strips, which is composed of 8 wells, and these 8 wells have which are the 4 wells are covered with a barcoded strip containing the SMC information, and then the reagents which are used for the conventional ELISA testing are already pre-filled into the wells. You have the conjugate, the sample dilution buffer, and the substrate, and the initial 4 empty wells is where the sample is pipetted and the ELISA reaction is carried out. So there is no need for any extra consumable, any extra pipetting, any extra use of reagents which is required in a conventional ELISA testing. All this is pre-fed in a strip. The wells contain all the reagents, and the sample also needs to be pre-fed into the well, and the reaction takes place, and then a OD is generated which is measured at 650 nanometers like any other ELISA test. So what is this Allegria? Allegria is an instrument which is an ELISA-based technology using these monotest strips. So it's a random access analyzer, and it has a combination of large autoimmune and infectious serology testing. Just a caveat, we as at Sabia are offering autoimmune testing as of now, and infectious serology testing will be soon available. And we have a large menu of over 135 assays with the unique SMC sensotronic memorized calibration. And currently we have more than 2000 global installations. So I'm showing out here what exists in Allegria 1, which is the first Allegria instrument. So the value proposition of having an Allegria 1 is that we can run up to 30 different parameters in one particular process flow. So you have a free and flexible choice of up to 30 patients with different test requirements, and they all can be run in one go. So you can run 30 different test strips and get results within 90 minutes. Also, simultaneous handling of quantitative and qualitative tests can be done, and the serum and stool processing, sample processing can also be done simultaneously. So otherwise, stool samples and serum samples require different batching. Out here, you do not need any separate batching. You can process even one sample to maximum of 30 samples in one go and get all results in 90 minutes. And this will sort of increase the value proposition of a lab doing autoimmunity testing by offering a very good tact to the patient, to the clinician and the patients who send a test to the premises for the report generation. So for example, you have 6 patients with different parameters to be tested. So all of them can be tested in one go. There is no need for separate batching, which is required. So different samples, different parameters, random access instrument. So what I talked about was Allegria 1. Allegria 2 is also available. So these are the comparisons between Allegria 1 and Allegria 2. Allegria 1 is a semi-automated instrument, whereas Allegria 2 is a fully automated instrument. So you can have continuous loading of samples and processing of samples for autoimmunity testing. The throughput in Allegria 2 is 240 tests, whereas it's 90 tests in Allegria 1. The test capacity for Allegria 2 is more than Allegria 1. It is 80 assays in Allegria 2 and 30 assays in Allegria 1. And Allegria 2, you can load up to 112 primary sample tubes for testing. And the sample type which can be tested on both the instruments are the serum, the plasma, and the stool samples. So definitely, if it's a high volume autoimmunity testing lab, Allegria 2 would be an ideal instrument for that particular lab. Whereas if it's a low to mid volume testing autoimmunity lab, Allegria 1 would be suitable for that particular laboratory. So this is the menu which is available on the Allegria platform, and these are the disease-specific biomarkers which are available for rheumatoid arthritis, for thyroid, for bone metabolism, for ANCA and vasculitis syndromes, for diabetes, and the various markers associated with the autoimmune connective tissue disorders, for antiphospholipid syndrome for particular thrombosis testing, and calprotectin for stool diagnostics, for different for diagnosing inflammatory bowel diseases, and then a huge menu which is available for the gastroenterology, autoimmune gastroenterology diagnostic parameters, and I would be just talking about them subsequently. So after talking about the Allegria instrument, now what I would like to bring forth is certain value propositions which any lab who is testing on an Allegria instrument will get when using the Allegria monotest strip. So we'll be talking about first rheumatology testing and what Sabia has to offer, which provides excellence in rheumatology diagnostics. So I'll just quickly go through rheumatoid arthritis. You are all very well aware the clinical signs and symptoms. It's an autoimmune disorder affecting the small joints and subsequently the bigger joints with extra-articular manifestations. And there is a significant affliction in the population worldwide, and women are 3 times more affected than men. So the diagnosis is based on the clinical symptoms, the imaging methods, and the laboratory analysis. And as you are very well aware, we need to detect rheumatoid factors, or the RA factor as it is commonly called, and also antibodies against specific proteins or peptides called as citrullinated peptides or proteins, ACPAs. And early diagnosis is imperative in rheumatoid arthritis to prevent severe disease manifestations and to prevent irreversible damage. So the ACR-ULR classification of 2010 lists the clinical weightage for diagnosing rheumatoid arthritis, as well as the laboratory or the serology and the serology aspects of diagnosing rheumatoid arthritis, in which their emphasis is put on detection of rheumatoid factor and anti-citrullinated peptides or protein antibodies. So any clinician, when they want to diagnose rheumatoid arthritis, they need testing for rheumatoid factors and ACPAs, apart from acute CRP, ESRs, and the clinical affliction of the joint. So testing for RF and ACPAs is very important. So when we talk of rheumatoid factors, it is good to know that rheumatoid factors are mainly antibodies, IgM antibodies, which act against the FC portion of the IgG, and they are detectable in majority of rheumatoid arthritis patients. So they have a very high sensitivity for rheumatoid arthritis, but not very good specificity. So this is definitely has been one of the classic and most frequently performed analysis for rheumatoid arthritis, but definitely there is a limited specificity attached to this particular marker with a lot of false positives which exist. So to negate or improve the specificity of diagnosis, the detection of citrullinated peptides and becomes very important. And so antibodies against cyclic citrullinated peptides have been put forth as a very important marker. And currently the antibodies which are available, they are available against filaggrin. So these are synthetic proteins. Filaggrin is filament aggregating protein, and this has become very important. The citrullinated form of filaggrin has become a very important part for the diagnosis of rheumatoid arthritis. So this citrulinated peptides undergoes an in vitro cyclic transformation to increase the epitope exposure, and so synthetic CCPs with exposed epitopes are now the most frequently used for detection of IgG antibodies. But the relevant point here to understand is the antigen being used for detection of these antibodies is filaggrin, which is a protein present in the skin and is not a native joint protein. So whether the lab is using CCP1, CCP2, or CCP3, they are not using the native joint protein for detection of antibodies, but filaggrin, which is a protein not found in the joints. So they are basically detecting cross-reactive antibodies. But nevertheless, they have served as a very specific and sensitive marker for rheumatoid arthritis compared to the rheumatoid factor. So when you see the sensitivity and specificity the markers offer in combination, definitely the diagnostic efficiency increases when you test for both CCP as well as rheumatoid factor. So just testing for both, your diagnostic efficiency increases up to 96%. So it is important that testing for rheumatoid arthritis, you have to test both for rheumatoid factors as well as CCP proteins. Now, Sabia has come up with a very unique proprietary marker, a patented technology, which is anti-MCV. So this is labeled as an outstanding marker for rheumatoid arthritis. So what is MCV? MCV is mutated citrulinated vimentin. So remember that rheumatoid arthritis is a pathology or a disease of the joints, and vimentin, which is a protein or a native joint antigen, it plays a very central role in the pathogenesis of rheumatoid arthritis and in generation of anti-citrulinated peptide antibodies. So this mutated vimentin is secreted by macrophages during inflammation and is detectable in the synovial tissue of the inflamed joints. So this vimentin, when it undergoes mutation, it is what is the native antigen, which has a central role in the etiopathogenesis of rheumatoid arthritis. So when detecting antibodies against this particular native joint protein offers a better diagnostic sensitivity and specificity compared to detection of cross-reactive antibodies which are detected through CCP testing against filaggrin. So this MCV again undergoes a in vitro citrullination, and that leads to enhanced exposure of the epitopes and recognition by autoantibodies. Therefore, it has been proven that it has a superiority over the existing CCP biomarkers, and there are many references which are available which sort of bring forth this value proposition of testing for MCV, and more so when you have the conventional seronegative rheumatoid arthritis, where both in a patient of rheumatoid arthritis, your CCP and rheumatoid factors are testing to be negative, then this becomes a marker of utility in those particular case scenarios where the patient can be tested for MCV also. So what are the significance of testing for antibodies against MCV? It is a sensitive and specific marker for rheumatoid arthritis. It is suited for early diagnosis of rheumatoid arthritis. Literature states that it can be detected up to 2 years or 24 months before the onset of rheumatoid arthritis, especially in patients who have a strong family history of rheumatoid arthritis. It has a strong correlation with disease activity. It has a prognostic value for a erosive course of a disease or a fulminant course in rheumatoid arthritis. It can also be used as for therapy monitoring. So for TNF alpha inhibitors, which are the therapeutics for rheumatoid arthritis, to monitor their efficacy, the MCV can serve as a marker which can help in monitoring or test the efficacy of treatment using those particular drugs. It is a most powerful biomarker for diagnosis of rheumatoid arthritis, and it is patently and exclusively provided by Sabia as a beautiful and a powerful biomarker for diagnosis of rheumatoid arthritis. So Sabia offers improved antigen recognition, which increases the diagnostic sensitivity and specificity for rheumatoid arthritis. So it offers not only MCV, which I have just talked about, where the native protein structure is used, which exposes up to 40 citrullinated peptides with a native protein conformation. It also has anti-CCP HS. So out here, the protein being used compared to the other conventional or the commercial available CCPs where the filaggrin is used, here the native protein is being used, which again is Vimentin. So both for MCV and anti-CCP HS offered by Sabia for rheumatoid arthritis, the antigen or the protein being used is Vimentin, which is increasing the sensitivity and specificity of the testing. So therefore, Sabia offers a unique diagnostic portfolio for rheumatoid arthritis by offering rheumatoid factors, anti-CCP high sensitive and anti-MCV. So this leads to generation of patient-oriented profiles to support the comprehensive diagnosis of rheumatoid arthritis. Now coming to what Sabia has to offer in connective tissue diagnostics. So when we talk of autoimmune connective tissue diagnostics, the first autoimmune disorders and the most common autoimmune disorders which comes to the mind is SLE or systemic lupus erythematosus. It's a very common autoimmune disorder. And in 2019, the EULAR and the ACR gave a classification criteria for SLE where the entry criterion was a positive test for ANA, and also this test has to be done by immunofluorescence using the HEP2 cells with a titer of equivalent or more than 1:160, or testing by a solid phase ANA testing, which has to be done with the immunoassay with at least equivalent performance. So with the variability which is attached with the immunofluorescence testing, EULAR and ACR both have given place to solid phase ANA screening by immunoassays also, but then the lab has to demonstrate that it is showing a equivalent performance to the immunofluorescence testing. So this was a very important change brought about by EULAR ACR for diagnosis of SLE. So the classification criteria for SLE, apart from the clinical criteria, it has certain laboratory criteria, and then laboratory criteria testing for SLE specific antibodies, that is the anti-dsDNA and anti-SM, has a very prominent place which helps in diagnosis, and also testing for anti-phospholipid antibodies, that is anti-cardiolipin and beta-2 glycoprotein I. So these are the antibodies which form the part of the diagnostic criteria and the classification criteria for SLE. So apart from ANA testing, to label a person as having SLE, you need an additional testing for these particular antibodies to fulfill the EULAR ACR classification criteria. So because dsDNA has a special diagnostic relevance in SLE diagnosis, the EULAR classification states that anti-dsDNA antibodies when tested with an immunoassay, they demonstrated more than 90% specificity for SLE. So it forms a very relevant and a highly specific biomarker for SLE, and therefore testing by immunoassay gives it a high diagnostic performance compared to a classical immunofluorescence testing. Now, what is important to understand is just having an ANA result does not make a person as having a autoimmune disorders, because there are a lot of differences in ANA prevalence and in ANA positivity. So the titer becomes very important. If you have an ANA positivity with a titer which is less than 1:160, it is not appropriate to classify that person as having an autoimmune disorder. Also, there are epidemiological differences in ANA prevalence. So we all know that ANA positivity is associated more with the elderly age group and is also seen more in the female population. So just having an ANA positivity will not be appropriate to label the person as having an autoimmune disorders. So it is very important that when you have an ANA positive result, the need of testing for appropriate functional autoantibodies to diagnose the disease, and if the disease is there, then to monitor the therapy subsequently. So along with just an ANA positivity, you need testing for the associated functional autoantibodies also. So this is the sort of a flow chart where we know that immunofluorescence assay is the staining starting point for ANA testing, and we have the 5 main staining patterns, and each pattern is associated with a presence of a different autoantibody. So you need to test when you have a positive titer along with this particular pattern. You need to test for the particular autoantibody. Also, you need to test for ENAs. ENAs are nothing but extractable nucleus antigens. These are over 100 antigens found in the cell nucleus, and they were originally isolated from the soluble saline fraction of the disrupted cells. And these are the 6 most clinically relevant ENAs which are associated with a specific autoimmune disorder. So apart from ANA test, we need testing for these particular biomarkers too. So this is a testing which needs to be done. And when we talk of testing for ANA and ENA specifically, the test methodology for ANA remains the immunofluorescence IF testing on Hep2 cells, whereas the testing for ENA remains the solid phase assays, the ELISA, the immunoblot, or the immunoprecipitation technique. The difference for testing for ANA, ENA is ANA definitely offers a high sensitivity but not high specificity, whereas testing for ENA, it is highly specific for an individual disease. So ANA testing or can be a screening test for autoimmune disorders, whereas ENA testing is a confirmation and a differentiation test to sort of classify and put a particular autoimmune disorder into its appropriate category after a positive ANA testing has been carried out. So this is how the algorithm goes, where the second line testing for functional antibody titers is done after a positive ANA result. So these are the various biomarkers, the nucleosome dsDNA, the Smith and the ribosomal P, which are biomarkers for SLE. Apart from that, the histone C1q and the SSA or the Rho antigen, which further differentiate it into which type of SLE or the LE is present. And also for Sjogren's syndrome, these are the biomarkers for scleroderma, for CREST syndrome, and for polymyositis, dermatomyositis, and RNP70 for MCTD, and so forth. So the idea is that, and just having a positive ANA test alone will not suffice. You need an additional test for these particular biomarkers to sort of differentiate which connective tissue disorder that person is harboring based on the clinical signs and symptoms. So this slide shows in a nutshell all the biomarkers which are associated with all the particular autoimmune connective tissue disorders, including rheumatoid arthritis also. So when we talk of ANA testing, Sabia has in its portfolio a test called ANA Detect, in which we have a well which is coated with 26 antigens, which are the most common and the most appropriate biomarkers which are relevant for picking up ANA, which is relevant for a connective tissue disorder. So if you have it acts as a complementary test to the conventional IFA testing and can be used as a complementary test to immunofluorescence to reconfirm or sort of confirm the presence of ANA in a particular patient. So ANA Detect is the test with the largest antigen coating which is available amongst the manufacturers, which has all the relevant coatings of the ENAs and the disease specific markers coated on a particular well. Now, thirdly, we come to Sabia's offering in antiphospholipid syndrome diagnostics or APS diagnostics. So antiphospholipid syndrome, as you are all very well aware, is an autoimmune disorder associated with thrombosis and pregnancy morbidity. And the patients, there are antibodies against phospholipids, the cardiolipins, and phospholipid binding proteins, specifically beta 2 glycoprotein 1. And they can cause myocardial infarction, stroke, or kidney attacks or pulmonary embolism. And recurrent abortions is also a very common feature. So the diagnosis is based again on clinical symptoms and laboratory methods. And for laboratory confirmation, testing is required for picking up lupus anticoagulant test by conventional coagulation disorders, and also by using testing for antibodies against phospholipids and phospholipid binding plasma proteins by immunoassays, that is ELISA or TIA or other assays. Now, the classification criteria and guidelines for APS has undergone a lot of changes from the time uh, it was first initiated in 1999. So the new 2023 ACR EULAR APS classification criteria, apart from the clinical criteria, labels that for laboratory criteria, we need testing for lupus anticoagulant as well as ELISA-based anticardiolipin and anti-beta 2 GPI, IgG, and IgM testing on 2 or more occasions at least 12 weeks apart. So the prominent or the most visible change which is apparent in the recent guidelines is the use of ELISA-based anticardiolipin beta 2 GPI testing for both IgG and IgM. So this was because to sort of cut down on the inter-technology variability that was seen, especially with the moderate to high levels of both these antibody levels, which are clinically significant. So because there was a lot of variation amongst the automated platforms at this particular level. So therefore, the consensus was that they should be tested only on standardized ELISA platforms and not on any other testing modalities. And also importantly, results of the analytical platforms should not be mixed. So any patient being tested on ELISA should be tested subsequently, even for diagnosis and monitoring on an ELISA platform only. So there is from Sabia's side for coating for Allegria monotest strip, it offers a unique proprietary antigen coating procedure of negatively charged phospholipids. So also there is a additional coating of purified human or native beta 2 glycoprotein, which is present as a cofactor. So this increases the sensitivity of antiphospholipid determination, which offers excellent accuracy, reproducibility, and consistency. Now we will talk about Sabia's offering in ANCA disease diagnostics. So ANCA, as you know, is an antibody which stimulates neutrophils and induces vascular damage and causing vasculitis, especially in small and medium blood vessels of the body. So these are antibodies against antigens in the granules of neutrophil granulocytes and monocytes. And the common antibodies are against the myeloperoxidase antigen, what is called as p-ANCA, based on the fluorescence given on immunofluorescence, and proteinase 3, which is called as c-ANCA or cytoplasmic ANCA, again based on the type of fluorescence given on immunofluorescence testing for these ANCA antibodies. So ANCA can be tested by both immunofluorescence assay as well as ELISA. So the patterns are labeled as c-ANCA and p-ANCA respectively on immunofluorescence, whereas the relevant antigen is detected by ELISA testing. So for c-ANCA, the relevant antigen is anti-PR3. For p-ANCA, it is MPO. And then we have the disease associations for these specific markers, and so these are the diseases listed with the specific ANCA markers, and these are ANCA associated vasculitis markers. So testing for these particular diseases, it is imperative to test for both the antibodies on IFA and ELISA. So there has been a change in the type of testing strategy for ANCAs on immunofluorescence and ELISA. So there is a new 2017 international consensus on testing for ANCAs. And what this approach is, so we had in 1999 the old conventional approach in which initially the testing for ANCAs was done on immunofluorescence assay, and then the relevant antigen testing was done using the immunoassays. But now 2017 approach is that the initial testing in any suspected case of vasculitis has to be done initially by immunoassays for PR3 ANCA and MPO ANCA. And if these are negative by any immunoassay and the pre-test probability or the clinical probability is very high, then a reflex immunofluorescence testing has to be done. So what is relevant is that now solid phase assay testing has become the first line testing for autoimmune vasculitis diseases compared to immunofluorescence, which was the old first line testing since 1999. So in Sabia, there is an offering of anti-PR3 high sensitive tests. So this is labeled as high sensitive because this is a third generation ELISA for PR3 testing where there is a linker molecule attached to the plate of the ELISA plate. And this linker molecule offers better epitope availability for antibody detection. So it offers a very high sensitivity for detection against for anti-PR3 detection. So it has a sensitivity of more than 95%, specificity of 99%. So anti-PR3 is a unique value proposition testing available by Sabia for ANCA vasculitis testing. Also, Sabia has in its portfolio atypical ANCAs which are prevalent. So atypical ANCAs are which on immunofluorescence do not follow the conventional cytoplasmic or the perinuclear staining pattern, and detection has a role to because these atypical ANCAs are present in certain autoimmune disorders like rheumatoid arthritis, ulcerative colitis, and certain autoimmune liver disorders. So testing becomes important when testing for those specific disorders. Now coming to Sabia's offering in autoimmune gastroenterology and liver disease diagnostics. So we all know that autoimmune gastritis is an autoimmune disorder afflicting the stomach in which antibodies act against the intrinsic factor and the hydrogen potassium ATPase enzyme and cause pernicious anemia. So pernicious anemia can lead to vitamin B12 deficiency, and vitamin B12 deficiency can become severe if left untreated. So Sabia offers testing for both type 1 antibody and type 2 antibody for intrinsic factor, which both prevent uptake of vitamin B12. So for pernicious anemia, on Sabia's platform, you can test both for IF type 1 antibody, also for IF type 2 antibody. Celiac disease is a disease of the small gut and very prevalent in India. It is a very gluten sensitivity, and so it needs no big introduction or elaboration because this is a very common disorder prevalent all throughout the India. So what is important to understand is that the diagnostic markers for celiac disease are the anti-tissue transglutaminase, that is the TTG, IgA, IgG antibodies, and the anti-DGP, IgA, IgG antibodies, where DGP stands for deamidated gliadin. So the criteria for diagnosis is basically testing for anti-TTG and anti-DGP. Gliadin previously used to serve as a marker, but it was subsequently found that it is not specific for celiac disease. So testing for gliadin now no longer forms a part of the guideline. So this is the ESPGHAN guideline for diagnosis of celiac disease, where testing for TTG, IgA, IgG, and the DGP, IgA, IgG or becomes very important, and also testing for endomysium antibodies. So endomysium antibodies, which are very highly specific for celiac disease, are available by immunofluorescence, whereas TTG and DGP can be tested on any solid phase assay, and Sabia has it in its portfolio for celiac disease diagnosis. Inflammatory bowel disease is an autoimmune disorder of the large bowel. So we have Crohn's disease and ulcerative colitis. So it is very important to differentiate between inflammatory bowel disorder and the bowel disease or the irritable bowel syndrome, because the symptoms are overlapping. So IBD is an autoimmune disorder, whereas irritable bowel syndrome is basically not, there is no autoimmune element attached to it, but it is more of a psychosomatic disorder. So we need to differentiate between these two disorders. So calprotectin is a test which has been recommended to discriminate between IBS and IPD, and it is an inflammatory marker secreted by the neutrophil granulocytes, and it is tested in the stool. So Sebia has in its offering to test for both calprotectin as a marker by doing stool testing, and it can be done on the Allegria platform. Also, to differentiate between the inflammatory bowel diseases itself, between Crohn's disease and ulcerative colitis, we have the antibodies ASCA, which is anti-Saccharomyces cerevisiae antibodies, and atypical ANCAs. So when you have an ASCA positivity, it is more as a pointer towards Crohn's disease, whereas if you have ASCA negativity and atypical ANCA positivity, it is a marker more towards ulcerative colitis. So you have ASCA as well as atypical ANCA testing available on Sebia platform, or rather the Allegria platform, to test to differentiate between Crohn's and ulcerative colitis. To test for autoimmune liver disorders is very important. So for testing of autoimmune hepatitis, these are the relevant laboratory markers which are important. So we need to test for ANA as well as anti-smooth muscle antibodies called ASMAs. And then we test for anti-LKM1, anti-SLA, anti-LC1, and p-ANCA. So these are the diagnostically relevant antibodies which form the part of a diagnostic testing algorithm for autoimmune hepatitis. So when we talk of autoimmune hepatitis, there are two types of hepatitis, AIH, autoimmune hepatitis 1 and 2. For autoimmune hepatitis 1, these are the antibodies which are to be tested, and autoimmune hepatitis 2, which is prevalent more in the pediatric age group, these are the antibodies which need to be tested. So all these antibody testing, the antibodies, the facility for testing for these antibodies is available on the Allegria platform. Primary biliary cholangitis is another autoimmune disorder of the bile system, and in this, the diagnostically relevant antibody is the AMA, or the anti-mitochondrial M2 antibody. So testing for this is also available on the Allegria system. Additionally, very unique markers which are additionally available on the Allegria system are the anti-SP100 and anti-GP210 antibody testing for PBC, which have a prognostic significance. So positivity is a marker towards kind of a worse prognosis in this particular disease. So you can additionally test for anti-SP100 and anti-GP210 on the Allegria platform. Primary sclerosing cholangitis, autoimmune disorder of the bile duct. So the relevant antibodies to be tested are the ANA and the asthma, and around 80% of these patients also have a positivity for atypical p-ANCA. So testing for atypical p-ANCA is available on the Allegria platform. Now we come to a very relevant and a moot question when we talk of autoimmunity testing. So is immunofluorescence assay still the gold standard? This is something which has been brought forth in the guidelines that immunofluorescence assay is a gold standard. But when we take the practical case scenarios or the practical realities, do we still consider it as a gold standard? So there is the slide which detects that there is a lot of interpretation variability for immunofluorescence assay which exists within the laboratories and between the laboratories. So there was this publication in 97 which stated that the interpretation variability of IFA range from 36 to 51%, because it's a operator dependent technique, it's a manual technique. It is based on the competency of the operator. It has a lot of pre-analyticals involved with it, the type of the cell substrate, the type of conjugates being used. So there is a lot of variability which comes associated with this testing. So considering this variability, can it be considered as a gold standard? The question is still open out there. So what are the advantages when we talk of IFA testing? Because it forms a initial screening test for anti-nuclear antibody, which is the first line testing. So it is a gold standard as laid down by the guidelines, simple processing, and is a sensitive screening assay, and definitely it offers detection of multiple antibody patterns. But the disadvantages are quite high. There is a need for a fluorescence microscope with the need for an experienced technician as well as a pathologist. There is a lot of subjectivity of interpretation. There is very low level of standardization, low level of automation, and very time consuming and labor intensive. So considering this pros and cons, it is not always necessary that the result being generated by an immunofluorescence assay is what is actually matching the pre-test probability of an autoimmune disorder in a particular patient. Also, there was this paper brought forth by the EFLM, EASI, and ICAP, which said that when we talk of ANA, also ANA alone is alone also not a very sensitive marker, a very specific marker for autoimmune disorder, because it can be found in a substantial part of apparently healthy individuals, children, adults, and elderly, and this should be taken into account when interpreting test results. So it brings forth the value proposition that when you are testing for ANA or autoimmune disorder, you have to combine both the HEP2 IFA testing with solid phase assay testing for autoimmune disorders to increase the clinical value of the report. So it ideally says that both IFA testing as well as solid phase assay testing are complementary tests which increase the clinical value and which increases the likelihood ratio of a patient having an autoimmune disorder if the pretest probability is also very high. These are additional publications which says that the combination, this publication states that the combination between indirect immunofluorescence and solid phase assays adds a value for ANA detection. And this publication lists the strengths of combining HEP2 IFA with solid phase assay, where it states that combined positivity of in both the platforms has a higher likelihood ratio for disease than just a single positivity, whereas a combined negativity has the likelihood ratio for a disease. So ideally, the laboratories should, or any good centered performing autoimmunity testing should have both the technologies with it so that it offers a proper, or it sort of gives an appropriate report to the clinician based on the pre-test probability for that particular patient. Also, this publication states that clinicians should be aware of the type of assay used for anti-nuclear antibody detection and the advantages and disadvantages of using immunofluorescence assays and solid phase assays for screening. And immunofluorescence assays can vary in performance between different laboratories, whereas the performance of fully automated assays is more consistent. So the idea is that number one, the clinicians also should be aware of the advantages and disadvantages of the testing for a particular biomarker. It has been done on which particular platform, and they should be in continuous discussion with the lab so that they come to an appropriate diagnosis. And also that immunofluorescence assays, has been stated earlier, has lot of variability. There is no standardization, whereas some amount of standardization exists in the fully automated solid phase assays platform. So it is important to understand the differences among the assays are not only important considerations when screening and diagnosing patients, but also when using these assays for classifying patients. So it is very important to understand that there are advantages and disadvantages of both the assays. So in a nutshell, both assays act as complementary technologies for each other to increase the likelihood ratio of presence of a particular autoimmune disease in that particular patient. So just to end my session, just to sort of, in a nutshell, summarize all the unique value propositions and offerings for autoimmune testing which the Allegria platform has. So the Allegria Monotest technology, you can test for any autoimmune disorder at any time. Anti-MCV or mutated citrulline vimentin is a unique proprietary antigen for early rheumatoid arthritis detection. ANA Detect, which acts as a complementary ANA detection for immunofluorescence. It's a unique 26 antigen well coating for ANA testing and screening. Anti-CCP high sensitive and anti-PR3 high sensitive are available respectively. CCP HS for rheumatoid arthritis, PR3 high sensitive for ANCA-associated vasculitis. The cardiolipin testing is quite stable because of the presence of beta-2 glycoprotein well as a cofactor. So there is coating optimization leading to very accurate and sensitive result generation. And in liver panel, all the unique markers and the complete panel is available for testing both for autoimmune hepatitis 1 and type 2, so that the patient can be tested as per the listed diagnostic algorithm for these hepatitis syndromes. So with that, I would like to end my session. Thank you for your patient listening.
Thank you. On behalf of Sibia India and Biotechnica, I take a pleasure to thank all the speakers for sharing their expertise and knowledge on autoimmunity. I also thank the entire audience for actively listening and participating and sharing their questions on the chat box. If you still have more questions, you can type into the chat box so that our experts and including me, I can answer those questions. Still, if you have more questions, you can note down my email ID. You can always reach out to me at n.kapoor@cbr.com. With that, we close our webinar here. And as we say that March is an Autoimmunity Awareness Month, so let's take and pledge to raise as much as awareness about this disease, and let's try to talk more about importance of early diagnosis of autoimmunity. So with that, we close our webinar. Thank you so much, and once again, thank you all. Thank you.